Good afternoon, everyone, and thanks so much for joining us here today. Uh, Hospitals have been telling us for quite some time that there's a lot of valuable information that exists in the EMR, but accessing it and using it efficiently can really be challenging. So today, our product lead, Ian Robinson, will be providing an overview of how enhanced EMR integration for DQA can help with this. As we've done in the past, today's webinar will be recorded and shared with all of you afterward. And to assist with the recording quality, we've turned off everyone's mics and cameras. But as we've done, there is time set aside for a Q&A towards the end of the session. So don't hesitate to drop your questions in the chat at any point throughout so we can address them during this time. And rest assured, if we don't get to them today, we'll follow up afterward. So I'll hand it over to you, Ian. Take it away.
Awesome. Thanks, Jamie. Thanks for the intro. Yeah, I'm Ian Robinson. I lead the product team at 3Terra. I'm incorporating new features into DQA and kind of building on the platform. So we're here today to talk about EMR integration. And before we kind of talk about it and show it to you, just want to summarize kind of why we're launching this. Reconciling EMR data, as Jamie mentioned, against coded abstracts remains hard. Like advanced hospitals are uploading hundreds of files into DQA a year. It's cumbersome and difficult. And so we're trying to improve that for you. So much of coding is translating what's in the EMR, but items can be difficult to find. DQA really presents a unique opportunity to take that data that's ingested, focus coders on the items that make a difference, and eliminate noise as much as possible. And EMR integration has been a constant item of feedback from clients, like, help us reduce the effort involved in reconciliation, create more checks, present information earlier. Like, we heard you. We took that feedback and we've been working for over a year on updating DQA and building direct feeds into it. So what is it? Well, the base platform looks like this. We bring in coded data and we do integrate it with external data from files and databases, but for simplicity, I'm just excluding that from the diagram. And the change we're making is that we're just going to start pulling data directly out of your EMR, starting with orders, procedures, medication administration, location. And what benefits does that have? I mean, really, it can benefit the hospitals in multiple areas. Encoding gives them a tool to consolidate all that information to a single area and highlight and identify the things that are most important. On data quality side, can reduce the amount of time required to conduct review, reduce context switching, and we can build way more checks, weight-bearing ones for flagged interventions or other attributes, things that are ELOS altering that can impact conservable days, funded volumes like GI endoscopy and other surgical volumes and other patient attributes too. And for DS, less work, less work pulling the data and providing files to upload. And then there's also, there's a benefit of having a consolidated platform that has this EMR encoded data together to access and be able to use that for analysis. So before we dive into kind of a show and tell, and I show you what we've got, I just want to outline what the scope of what we're doing right now is and kind of availability. These are the data sets that we're starting with. I think there's a lot of unlocked value in these to identify important parts of coded records that can be reconciled. Initial subscribers to this are going to have the ability to shape the direction of how this evolves from like what new data we're bringing in, what additional checks and insights and things that we're highlighting to you. And from availability perspective, it's available now for Meditech and Cerner or Oracle Health. It's something that we've been working on for quite a while, and we're ready to move forward now, which is really exciting for us. Epic is coming soon. We're really looking for a strategic partner hospital to help us translate what we've done with Meditech and Cerner into that Epic EMR environment. So if you're interested in that, please reach out and we'd love to talk. So I want to kind of go through a couple of different case studies for how EMR data can change the way that DQA gets used in the hospital. The first one is EMR integration to support data quality review. How you can use this to kind of expedite review and make things better. The second is how EMR integration and DQA can actually help at the time of coding. And so we'll dive into this and go into case study number one. So case study number one, it's a simple chemotherapy check. Everyone who's used DQA has seen a check like this. A flight intervention was documented in an external system, but it's not present on the coded record. You know, Traditionally now it's up to the coder to go find that piece of information that's driving the check. And this is the information that you get in Data Hub. We give you a date. You've provided a file that indicates that there's chemotherapy, but really you need to go back into the EMR, find the source information to make sure that it's there so that you can appropriately code it. Well, let me show you how this can be better. With EMR integration, we're now showing, we're providing detailed data viewers to show you the specifics of the piece of information that's actually triggering that check. So then you can go back to the coding system, make the appropriate changes, and really remove the EMR out of the loop. You can see all the information associated with that we've brought in, and we're bringing in as much as we can. So just beyond the actual viewer, you can click that to see even more details on the right about additional notes, additional details that really to help you reduce the amount of time or number of times you have to switch between systems, between DQA and the coding system and the EMR. We're really trying to remove the EMR from this data quality loop. From our pilots, we think that there's a 15 to 30% improvement in weight and funded volume recovery using direct EMR integration with these data sets. And what I showed you is really just an example. The premise here is that we're spreading the breadth of things that we can do. We can build a broader suite of checks. We can check ED timestamps. We can check, for GI endoscopy reconciliation. We can do procedure checks. We can, medications that might indicate conditions like sepsis or interventions like parenteral nutrition. Like these are things that then we can further supplement and identify for you and check without additional effort on your part to, extract that data and upload it into the system. So in summary for case one, really it's just a way that we can expedite data quality review, less context switching, less system switching, and really get the information that's actually triggering the data quality check in DQA without having to go back and find it elsewhere. So for case study number two, we're gonna do a live demo. I'm gonna pull up the system here, and I'm gonna walk you through how it works. So this is DQA, our patient search interface. I've got a chart number here that I'm going to paste in, and I'll hit search. And this is going to bring up the cases that are in the system for that particular patient. There's a couple things I want to quickly identify. We are doing patient linking behind the scenes. So even though I entered in this chart number, the same patient at a different campus with a different chart number is also being presented. So you get to see a full patient history here for the date range you've got. You can see that these are coded records in the past, and then these two are not yet coded. And in fact, this last record is actually still in progress. So any information that we're bringing in for a record that hasn't yet been discharged is still accessible in DQA. I could hit this button and go and see the information in that as it's kind of being pulled in over time, even prior to discharge. So I'm going to pick this third record as the 7-day visit that we're going to pretend that we're coding here. I'll hit select, and immediately you get taken to the overview, which is what we're calling the patient timeline. There's a lot of information here, and it can be overwhelming. We're presenting a timeline for two reasons. One, to visually show you the information that's available, so you can really easily see what do we actually have for this patient for this visit. Second, it's also a means of filtering down what's really important. We will work with you to filter out what's just noise, so you don't have 1,000 medication records to look at on this view. But then even more so, there are things that I highlighted orange. Those are the things that we call insights. And insights are kind of attached to specific recommendations that could generate checks downstream once the record is coded. We want to give you insights at the time of coding so that you can kind of see the things that are most important. And you can filter this view using this button to really focus just on that. There's also an interactive view where you can actually drill in. So if we wanted to see what was happening around a particular insight, we can drill in and highlight a section of this view and actually see some of the information that down below for that range of time. I know there's a lot of stuff here. I'm just going to focus on one thing for the purpose of the time that we've got today. So I'm going to navigate on the left over here to an insights view. And this is a summary of all of the insights that have been generated from the information we've got. And I do want to point out, this is not just EMR information. You can see that there is information from CCIS, that is information that, would be uploaded. And so this will be a consolidated view of all information, not just the stuff from the EMR. So there is, we can see here at the top, if we have multiple sources of evidence, we can see that things get grouped together. So for ICU, we can see from the location data that we've got, as well as from CCIS, there's an ICU admission that's supported by multiple pieces of information, so that gets grouped together. And there's workflow associated with this. So if you are looking at something and you think, okay, that's not actually a valid, that's not a valid insight, you can dismiss that. And this works similarly to the downstream in data quality assist, where when you've got a check, you mark it as valid or invalid. If you just look at something in here and you mark it as dismissed, then it will not generate a check downstream. So we're only going to ask you to look at a piece of information once and make a determination. It's not gonna also then prompt you later on if you determined it was not correct and didn't want to code it. I just want to focus on one item here, and we'll focus on the gastroscopy. And so, this here is we've been working with lots of hospitals to help close any gaps in GI endo volumes. And now we're able to reconcile that data from the EMR or other source systems. And so we can see that there's a gastroscopy that's being generated here. We can click that, and then that will automatically take us to the EGD record here to show us all the information that's actually triggering this check. And then additionally, all the rest of the details that came out of the EMR associated with that, really to, again, try to help you get all the information that you need in one consolidated view, so that reduce the amount of source system switching. If you're using this at the time of coding, this also moves data quality upstream, where you're then you're doing data quality work while you're coding, so that you get the first record is going to be as accurate as possible. So let's fast forward. Now we've completed coding the record. We can click this live refresh button at the top, and the audit will be done in DQA immediately. That's really helpful because there's some things that we can't catch prior to the record being coded, things like QBP near miss or a most responsible diagnosis review. Those are things that we have to have the coded record to be able to do. And we're just trying to enable you to touch the record only once. So you code the record, use DQA at the time of coding, live refresh, you can do the retrospective review if anything happens, and then we can kind of close that record off, and you won't need to load that context, won't need to read into our mind about what that record actually is. And granted, this is a process change, so let's chat about that really quickly. Excuse me. This is a kind of the coding process that would change slightly in the way that I kind of described, where you open the visit in DQA, you'd code the abstract alongside DQA, use the insights and data presented in DQA to make sure that the important things are captured, and then just mark things as reviewed or dismissed as you need to make sure that to reflect that in the system. Then you can live refresh, immediately refresh the abstract in DQA. You'll get any of the post-coding data quality checks. Again, those dismissed insights piece of information will not generate DQ checks, so that you've already kind of done that work and eliminated that. And then you can review those records, make any updates, and kind of loop as you need to. Live refresh it again to make sure that something's been resolved and reflected. We're trying to upstream data quality, move that data quality to the time of coding through this process. And you're eliminating and reducing the amount of retrospective review that needs to happen. So to summarize our second case study, you get a consolidated view of data, helping to identify critical pieces of information that are important to capture on the coded record. We're moving data quality to the time of coding to have that capability and touch the record only once. And you can get immediate feedback after you've coded a record or made a correction, reducing that the downstream review that has to happen. So to reiterate kind of what I mentioned earlier, this is available now for Meditech Expanse and Cerner Oracle Health. Early adopters are being offered introductory pricing as this offering matures under kind of the guidance of the hospital community, in the same way that DQA continues to mature over time. Over the next 6 months, we're going to be rounding out additional data sets to bring in, new checks being developed, and we'll really be working partnering with these early adopters to build out what this capability is. We are onboarding hospitals right now, so if you're interested, make sure you contact Jamie to reserve your spot in line. And I just want to restate, we are for Epic, we're looking to develop this. We're actually in the process of moving forward with that, but we are looking for kind of a single partner hospital to really help us translate the value that we have in Meditech and Cerner over to the Epic environment. With that said, I'll pass it back over to Jamie.
Awesome. Thanks, Ian. That was great. So there have been a few questions coming in separately that I'd like to start with. Just give everyone a couple minutes if there are any others that want to drop their questions in the main chat as well. So, Ian, just to start, there was a great question that I think a lot of people might have at the top of their mind. This all looks really great, but how much of a burden is this going to be on hospital IT?
That's a good question. We've really designed this to kind of be as seamless as possible, the same way that we have with DQA. There is some initial setup required to access these interfaces to extract data out of the EMR, but on an ongoing basis, 3Terra is responsible for extracting, validating, integrating the data, answering user questions about it, making new checks, and addressing any inaccuracies. And really, on an ongoing basis, the IT burden really should not change very much relative to the base DQA platform.
Great. Two questions that are closely aligned. One is I'm gonna give you both at once, okay? The first one is, could this replace DI extracts that are currently being provided? And then the second one that kind of goes along with this is, I heard other systems, so data from other systems. Does that include the data that's currently being sent directly? And so would this go to a SQL table rather than through a file?
So I'll answer the first one. The DI extracts that we currently get from hospitals, absolutely. This like I'll say should, but will replace that process where the intent is that we can completely eliminate you providing manual data that you are sourcing out of the EMR to begin with. So that's something that you wouldn't have to do on an ongoing basis anymore. That would be automatically brought in and processed and then be available in DQA to kind of do the inpatient and outpatient checks that way. The second question, or sorry, second question. I think the answer is yes. I mean, we would not be like we're going to pull that information in directly. We're going to make it available in the back end in the database, so you would be just like pulling it, or we're pulling the data in from. It's not necessarily from SQL. Depends on the EMR, but we would be storing it in SQL. And frankly, if there's any kind of other extraction we need to do from a SQL database, that's something that's pretty straightforward to do.
Amazing. All right, questions are starting to come in here. You mentioned integrations. Have any of your sites completed a privacy impact assessment on any integration?
It's a great question. We haven't done any privacy impact assessments on these integrations because, again, this is all still living in the hospital environment. So the integration that's happening is from DQA that sits on premises to the EMRs within their infrastructure. So we haven't done any privacy impact assessments on that because it lives within their environment.
Great. And then last question we've got here. Will coders have their own login accounts or is it still single user access?
Coders do have their own login accounts. Like when you log into DQA, you are associated with your own specific login. So if there's something that you're looking to change based on your login, that's certainly something that we can do, and we can talk to you about offline.
Amazing. All right. Looks like those are all of the questions that have come through so far. As always, don't hesitate to reach out after the webinar and we'll share the recording as soon as it's available. So if you have any follow-up questions or something you didn't catch the first time around, we can help you with that. Thanks, Ian.
Thank you, Jamie. Appreciate it.
All right. So We will share the recording with everyone as soon as it's available. If you are interested in leveraging your EMR data in DQA, please reach out. Feel free to contact me directly. Any of our team members are happy to help with this. And as always, we value your feedback. So we're going to drop a survey link in the chat here. Please, if you can take a couple minutes and provide us your feedback. We are still doing the raffle for $50 gift cards each month. So congratulations to our April winner. And thank you all for joining us.